everybody for being here today. I know we have some people joining as we're talking, and this will also be recorded for later if people want to come back and watch. I'm really excited to talk with you all about today about something I'm very passionate about, which is treating hepatitis C and ending the hepatitis C epidemic. So just wanted to go over a few objectives for today. My goal is to have people leave and feel empowered to treat hepatitis C in their settings, or encourage providers in their settings to treat and provide resources to make that treatment so much easier. We'll be talking about some statewide programs that have helped boost our support for hepatitis C treatment across the state of Missouri. So we don't get to use the word cure much in medicine, but we have a cure for hepatitis C. The landscape of hepatitis C treatment has significantly changed since its discovery as a virus in 1989. Now, despite our ability to successfully test, treat, and cure hepatitis C, many people still don't know their status, or they lack the ability to access this life-saving treatment. This has led to over 15,000 people dying each year from hepatitis C and its related illnesses. Even worse, hepatitis C disproportionately affects persons who are in underserved areas or vulnerable population of patients. But there's something we can do, and your presence here today means that you're ready to help engage in some of those problem-solving activities. So with that, I want to jump in and give you a little bit of background about treating hepatitis C in general and in primary care settings. So as you can imagine, hepatitis C wasn't always something we did in primary care. We made the evolution and the switch from this being something that really only a specialist would provide treatment for back in probably the 2015, 2016, 2017 timeframe. And that was brought on by a study that was done called the ASCEND study, and it was through the CDC, the NIH, sponsored by Gilead. It was a multi-center, open-label, non-randomized phase 4 trial. There were 600 patients at 13 different FQHCs in Washington, D.C. They wanted to study whether or not this treatment would be successful in these primary care settings. And so they measured treatment retention and cure rates among patients who were treated by nurse practitioners, primary care physicians, and then specialist physicians. And the results demonstrated that Hep C treatment administered independently by primary care providers and nurse practitioners is safe and equally as effective as care observed with those specialists. So to give you a little perspective on where I come from and why I'm so passionate about this, I work at a FQHC called Swill Health in Kansas City, Missouri. We're an FQHC that's provided care to underserved patients in the Kansas City area since 1969. I'm the clinic director of our outreach clinic, which is a clinic that provides holistic medical care to Kansas City's unhoused population. We have a brick and mortar site in the central Kansas City area, and then we also have a mobile medical unit, which you can see on the screen, that provides medical care at our patients where they are across the city, whether that's at a campsite, at a traditional shelter, or even at a substance use recovery setting. We see a very, very high volume of patients with hepatitis C in our clinics, which is why starting in 2019, we decided to do everything we could to start treating Hep C in our setting. So to give you a little perspective on how we got to where we are now, we started treating in March of 2019, and we did a 100-day kind of pilot. This is something new for our organization, and we wanted to see if it was going to be something that was going to be effective and really make a difference for our patients. So we started in 2019. We just during that 100-day period, I had 50 total referrals to myself. I was the only person treating at that time. 8 did not engage in treatment, and that was for various reasons. Some of them didn't have a positive virus count, so they didn't need treatment. Some of them required a specialist. But we had 42 that engaged in treatment in that first 100 days. Even through the pandemic, through years 1 and 2, we were able to still maintain a really high retention rate for our patients. And we were able to have by year 2 over 156 patients who were either initiated or had completed treatment through those first 2 years. Now, to date, we're at around 530 patients that we've been able to cure through our program. We have a really high retention rate, and I'm not the only one doing all the treatment anymore. We've actually engaged several of our providers, all of my providers in my outreach clinic, and then several other providers across our organization are now successfully treating hepatitis C. And so, again, I hope that this can give all of you the confidence that this is something you can do. And often our patients aren't getting treatment for Hep C because when we are sending those referrals, we're asking them to navigate another healthcare system. And many of them find that difficult. We're asking them, and many of them have accessed care for the first time in your rural health clinics. And so being able to provide that holistic care, everything that you can do for them safely under your clinic setting is going to remove several barriers for your patients for treatment. Oops, sorry, let's just keep skipping ahead. All right, so now I'm going to give a brief overview about the hepatitis C treatment landscape. Today, hepatitis C can be effectively treated in a variety of healthcare settings, including rural health settings, community health centers, substance use disorder treatment programs, and even correctional facilities. The success of direct-acting antivirals has transformed hepatitis C from a chronic, potentially life-threatening condition into one that can be cured relatively simply with an accessible treatment course and making it possible for all of us to eliminate hepatitis C as a public health threat. So the CDC estimates that there are approximately 2 million people living in the United States with hepatitis C. New hepatitis C virus infections are almost 4 times as high as they were over a decade ago. And we estimate that 4 in 10 people with hepatitis C in the United States don't even know that they have it, which means they're not able to get in to get that life-saving treatment. Not surprisingly, new infections are also on the rise. Acute infections, there's a difference in the way that we categorize things. You can see here, acute infections is an infection that recurs within 6 months after somebody is exposed to the virus, and chronic infections demonstrate that kind of lifelong chronic setting for the untreated hepatitis C that can end up causing serious health complications like liver damage, cancer, and even death. We used to think of hepatitis C as something that really just impacted a baby boomer population of patients. But what I can tell you, even just anecdotally, aside from the data, is majority of my patients are under the age of 40. And we've seen that rise in conjunction with the opioid epidemic. And so we're really seeing hepatitis C and its impact of all ages. Unfortunately, as well, we've also seen a really large rise of rates of hepatitis C in pregnant individuals. The CDC, and we'll kind of go over some guidelines about screening here soon, but the CDC is now encouraging that we screen pregnant women with every single pregnancy. And so some of this has to do with the fact that now we are screening better. But when this data came out, we weren't doing as good of a job with screenings, and that started to improve better and started to help get women and their children linked to care, and pregnant individuals and their children linked to care after birth. But even amongst all that, we have these rising levels of infection among younger individuals and pregnant persons, so many people not knowing that they have an infection, and we're still not reaching enough people with hepatitis C treatment, which is unfortunate because we have agents that work. About 95% of people with chronic hepatitis C can be cured with these well-tolerated oral direct-acting antiviral agents. The number of people with hepatitis C in the United States who initiated treatment, however, with those direct-acting antivirals had actually declined between 2015 and 2020. To eliminate hepatitis C by 2030, which is an overarching goal, at least 260,000 people need to be treated annually. We'll talk a little bit now about hepatitis C elimination. So there's several ongoing elimination efforts, not only in the state of Missouri, but nationally. there is a national hepatitis C elimination program or plan that was put on by Rachel Florence and Francis S. Collins. Rachel Florence is the advisor to Francis S. Collins about hepatitis C, and he is the scientific advisor to the president. There are a lot of national pushes to get more data and information about who's being treated and how many patients and persons are currently infected with hepatitis C that need treatment. There's some ongoing efforts through the Center for Health and Policy and Innovation of Harvard Law School and the National Viral Hepatitis Roundtable. More specifically, though, in the state of Missouri, we have had really great champions through the Missouri Department of Health and Senior Services and their viral hepatitis department. In 2022, Missouri's first hepatitis C elimination plan was created called Mo Hep C, Show Me the Cure. Also, we'll talk a little bit more in depth in later slides, but Missouri Health Net's Project Hep Cure has had a huge impact. And then we have Project Echo, the hepatitis C Echo, that has really made available to providers some timely treatment advice and education surrounding hepatitis C. This is a quote from Rachel Florence from the National Hepatitis C Elimination Plan that I just really love, so I'm going to read it to you. But it is rare to have the opportunity using a simple and safe oral medication to eliminate a lethal disease, but that's the situation we're facing in the United States. So our Missouri State elimination plan was created to increase access for hepatitis C prevention, testing, and treatment for all Missouri residents. The goal of this plan was to create a plan that could help increase this universal testing, improve healthcare outcomes for people living hepatitis C, and hopefully through all of that, prevent new infections. The elimination plan pillars focused on access to services, provider development, which I was pretty active in. I was the co-chair of that pillar, focused on providing resources for healthcare providers to treat confidently in their settings, education, collaboration, and awareness, surveillance metrics, and then continued policy and advocacy. So this slide might look familiar to many of you, but it is all of the community health centers across the state of Missouri. And I like to show this in conjunction with another surveillance map of hepatitis C. Think about your setting, think about where you're at, and think about these clusters of persons with hepatitis C through this heat map and where they might possibly be able to go to get treatment. Many of those persons, especially in rural health settings, may not have access despite having available healthcare centers in their area. So it's so important for us to continue to push to get more and more providers ready and able to provide that treatment in their settings. So Project Hep Cure is an initiative to cure hepatitis C with prescription of a medication that's a direct-acting antiviral called Mavyret. Anyone who has Missouri Health Net coverage and is tested positive for hepatitis C is eligible for this treatment. This has been revolutionary. I can't talk more highly about this project. It has really changed things in terms of reducing the administrative burden that used to be on providers with prior authorizations to be able to provide this treatment in their clinic settings. Prior authorizations can be a pretty big burden for providers and nursing support staff. If you have hepatitis C and you have Mo Health Net, you can go pick up your Mavyret same day if the pharmacy has it in stock. And again, for patients who are ready and willing to start treatment, that is huge because you're capturing them when they are presenting with the desire for treatment. And even better, there's no copay or cost to the patient. Patients can also pick up the entire treatment duration at that first visit. So you could prescribe Mavyret as an 8-week treatment. Instead of prescribing 4 weeks with a refill, the patient could technically pick up all 8 weeks at once, which is great. Project Hep Cure has a really neat dashboard if anybody's interested in looking over it, with some county-specific data about persons who have been tested, diagnosed, treated, and providers treating hepatitis C in those areas. It's a fluid dashboard, and so if you go to the site that's listed on the bottom of this slide, you could get a little bit more accurate or up-to-date information. This screenshot is from early August, so I'm sure there's some more information to share and some more updates that you could take a look over for your county specifically. So something really remarkable about the state of Missouri is that we've removed so many barriers to care. We have an A+ rating from the state of hepc.org, and this means Missouri has taken away all of the barriers that we can think of that could keep somebody from getting access to Hep C treatment. So there's no prior authorizations through Missouri or through MoHealthNet. There's no fibrosis restrictions. There's no substance use restrictions. There are no prescriber restrictions, so you don't have to be a specialist. There are no retreatment restrictions. And it has really opened the door for more patients to gain access to treatment. So Missouri is doing a really great job, which is why it's so important to get more providers and more clinics open to the idea of treating Hep C in their settings. Something I always like to share in every presentation I do about hepatitis C is to make sure everybody leaves understanding that substance use, past, present, what have you, should never be a reason to deny somebody hepatitis C treatment. The idea that maybe somebody's not ready and they have other barriers going on is understandable to think about. But if somebody is presenting in front of you and they are open to that option for treatment, it's so important to provide that treatment option at that time. Something to keep in mind is that I think what holds people up is that, well, if they're still using, if they're still sharing needles, they could just get reinfected. So what's the point? Well, the point is reinfection is actually very low, and curing somebody of their hepatitis C is actually a method of treatment as prevention, because we are decreasing the amount of people that are out that could be able to spread the virus to another person. And so reinfection rates are low. If somebody's ready to get hepatitis C treatment in your office, that is the most important time to provide that treatment. So I'd like to give you a little overview of what that treatment process looks like. I won't go too in depth on the overall course, but I do want to give an overview so you can understand how easy it is to provide this in your settings. So the screening guidelines for hepatitis C were updated in 2020. I know that was a busy year for everybody, so this probably didn't get realized right away, but we are now screening everybody despite risk factors at least once in their life if they're an adult over the age of 18. And then again, we're screening all pregnant women with each pregnancy. So everybody at least once gets screened. And then you can do also a one-time screening regardless of age if they have any of the listed conditions. So that's being HIV positive, if they're on hemodialysis, if they persistently high liver enzymes, they've ever had an organ transplant before 92, if they've had an exposure as a healthcare provider, children born to Hep C positive mothers. And then we want to continue to do routine periodic screening for individuals who have ongoing risk factors. So the risk factor assessment is still important, even though we're doing routine screening for all persons over the age of 18, because this would give you the ability to rescreen that person as they present to an office for testing. So those are persons who are using drugs and potentially are injecting or sharing needles, syringes, or even just drug prep equipment. And then anybody who's received maintenance hemodialysis. Something to note as well is that regardless of risk factor, regardless of age, any person who's presenting, who's requesting Hep C treatment should always receive it, for testing, should always receive the testing regardless of disclosure of risk, because they might be reluctant to talk about the reason why they feel that they need to be screened. So there are several different lab tests that can be done for screening. The most common one that we see is the rapid point of care antibody test, and that can provide a result for an antibody within 20 minutes of the test, which is great. We do opt-out testing at my location on site and then on our mobile medical unit for all persons who present. And so we'll do HIV and hepatitis C screenings together, which is really nice. But if you're able to get serum labs, you want to make sure that you're doing a Hep C antibody that reflexes to an RNA. If that antibody point of care test was positive, then you're going to want to get additional testing. Just because an antibody is positive doesn't mean that the virus is active or that they actively need treatment. And so we are checking confirmatory labs called an RNA, which is the virus count for the patient. And so if that RNA is positive, then the patient does need treatment. So the CDC guidelines also were updated for hepatitis B and universal hepatitis B screening of all adults over the age of 18 and older using a triple panel. And so that includes the Hep B surface antigen, an antibody to the Hep B surface antigen, and the total antibody to the core antigen. So for test interpretation, when you're getting those results back to understand who needs treatment and who doesn't. If somebody is getting a point of care test and that antibody is negative, no exposure has happened for hepatitis C. If the RNA is also negative, then no treatment is indicated. You would continue your routine periodic screening if indicated. If your antibody is positive, so that point of care test is positive, but then you get the virus count and it comes back negative, what that potentially means is that they've had exposure to the Hep C virus, but there's no current active virus in their system. So no treatment is needed at this time. If there is a concern for recent exposure or ongoing risk factors, just continue to recheck that RNA. You wouldn't necessarily need to recheck antibody test because that is going to stay positive. That antibody is going to stay positive in their system forever. So if you know that they've had a positive antibody test, it would make the most sense for their routine periodic screenings to be an RNA test, that virus count, to see if that becomes positive. If their antibody is positive and their RNA is positive, then treatment's indicated, and you would want to then work with a provider and order that diagnostic evaluation. So there are clinical guidelines available that help guide the way that we provide treatment in our settings. And so that is through hcpguidelines.org. This is a really great webpage to mark. It's a fluid document, so it's continuously updated by the ISDA and the AASLD of all of the most recent guidelines for providing hepatitis C treatment. It's a really user-friendly webpage to use. So this is the part I'm going to kind of, not too quickly, but go through. I'm not going to dive too deep into the overall treatment, but again, I do want to try to illustrate how easy this is to provide in your clinic setting. So a pre-treatment assessment would be really just evaluating the patient's overall health and liver status. You can see the labs listed here. We'd want to get a CBC, check liver enzymes, check albumin, total and direct bilirubin, check kidney function through a GFR, an INR, obviously getting that Hep C RNA, providing Hep C and HIV and hepatitis B screening, and then a pregnancy test if indicated for your patient. We also want to evaluate fibrosis, and I'll talk in a couple of slides about what that means, but there are several tests that we can do even just through serum lab work, through a FibroSure or Fibro test to determine whether or not the patient might have suspected cirrhosis. Fibrosis just means there's some scarring and inflammation that can happen on the liver due to the inflammation that's happening from the infection. That inflammation stimulates production of these extracellular matrix proteins and can cause the liver to not function at the capacity that we want it to. Fibrosis is a precursor to cirrhosis, and establishing this level of fibrosis helps us predict that liver-related morbidity and mortality. So it is important to evaluate. There's several different ways that we can do that. Some of the options include, again, a FibroSure or Fibro test. FibroSure is proprietary to LabCorp. Fibro test is the Quest test for FibroSure. It will give providers a Medivir scoring, which tells them on this a scale from F0 to F4, how much scarring is on that liver. There's other options that like a FibroScan or doing some calculations that you can see on the right-hand side of this page here. You don't have to do them by hand. However, if you see this link at the bottom, there are some clinical calculators online. They can help support providers in determining whether or not they feel like their patients are at risk for cirrhosis. So this is just an illustration of what I'm talking about, of that healthy liver with no fibrosis all the way to cirrhosis. And again, determining this is going to help you evaluate the liver status of the patient, and most importantly, help you determine whether or not you need to do additional imaging through a fibrosis evaluation. So the reason we would evaluate somebody for fibrosis or when they have elevated fibrosis with an ultrasound is because there's concern for liver cancer or hepatocellular carcinoma. And so anybody with a higher score, an F3 or F4, we would want to be getting those ultrasounds, and they need to be continued every 6 months to screen for liver cancer and advanced liver disease. Some other reasons to get that is just if you have some lab results that don't feel that feel off. An elevated tumor marker called an AFP, if they have a low platelet count. Again, if you do some calculations and you notice their FIB4 is elevated or their APRI is elevated from that clinical tool we just talked about, those would be some reasons to get that ultrasound to do an additional workup. But always, always, always wanting to do it for persons with the elevated fibrosis levels. So some medication considerations. Most of our patients are going to come in taking something, and there's a really great tool online. The link is here on the right-hand side. It's www.hep-druginteractions.org. It was put on by the University of Liverpool. It gives you a selection of, you can pick what the Hep C medication is and then what medication the patient's taking. And it gives you a great list of what could be a potential interaction, what's not an interaction, and some different things that you need to monitor for. What I have listed on this page are the most common ones. And so for statins, I generally hold the statin for the duration of treatment unless they've recently had a heart attack or a stroke, and then I'm a little bit more cautious. And the reason we watch for that is because we're watching for an increase of something called rhabdomyolysis, which can cause kidney damage. There are some certain seizure medications that you have to be very careful about. There are certain acid suppressing medications that you need to be very careful about as well. That one's probably the most common one that's seen in clinics if somebody's on something like omeprazole or Nexium. These medications for Hep C work best in an acidic environment. So for suppressing all that stomach acid, there could be a risk of the medication not being as effective. So it's something to keep in mind if that patient can't come off that medication, making sure that you're staggering it apart and definitely not taking them together, and then watching for that virus count to trend down. We'll talk about that in a few slides as well. So some referral considerations. The biggest takeaway from this slide should be manage the patients you feel comfortable managing, and there are resources to help support you when you don't feel comfortable. I suggest starting with patients that seem straightforward and referring those that might have more complicated presentations like co-infections, history of organ transplant, and cirrhosis, decompensated cirrhosis where you suspect that. But you don't have to refer right away. There are some resources like Project Echo that can help support you in your clinical decision-making for those patients. So let's see. The medications, and we'll talk a little bit more about the Echo in a couple slides and the clinician consultation center, but to get through some of this treatment support. So these are your medications that you're going to be using for hepatitis C. We got Mavyret, we have Epclusa, Ensign, Harvoni and Zepatier, a little less common, and Vosevi is used specifically for patients who have had treatment failures. The two most common that you're going to be seeing are Mavyret and Epclusa. So these are direct-acting antivirals. They're a combination of antiviral drugs that target the stages of the Hep C virus reproductive cycle. They're much more effective than older treatments such as ribavirin and interferon. I get a lot of patients into the clinic who, almost refuse Hep C treatment because they say, well, my friend got that back in 2004 and they were terrible and it didn't cure them and all this stuff. And there's a lot of myths out there about Hep C treatment. And the important part for patients to leave with is understanding that the medications now are much more effective than they were before. They're much more accessible, and it's so important for patients to have access to them. There are some really great simplified treatment guidelines available through hcvguidelines.org. But basically, if you got a patient with Hep C, they don't have cirrhosis and they've never had treatment, which is the majority of our patients, and they don't have significant kidney disease, you can start them on Mavyret or Epclusa. And no, like very minimal monitoring is required for these patients. I typically have them come back at the 4-week mark and the 8-week mark when they finish. That's mostly just to help assess with compliance, make sure that patients aren't having an issue accessing or taking their medications. But again, for Medicaid beneficiaries, they could pick up all 8 weeks of their MAVRIT at the same time and be able to take that successfully. So just briefly, there are some different reasons why patients would take alternative medications or very specific medications. So if somebody has compensated cirrhosis, so their liver is cirrhotic but still functioning at a capacity, then they can still have either Epclusa or Mavyret. If they have decompensated cirrhosis, which means they're showing signs of liver failure, which is they get the big belly with ascites, having it's what's called encephalopathy that you could do some scoring for as well. They would likely have to be on a medication called Epclusa plus ribavirin, and those would be ones that we'd want to refer to GI and hepatology because they would be need consideration for liver transplant. If they've had prior treatment with Mavyret or Epclusa and that has failed, then you would want to put them on a medication called Vosevi. It's a 12-week treatment, and just really making sure that you review medication adherence, their medication lists, and any substance use that could be keeping them from taking their medications consistently. Again, I'll scream it from the rooftops. Missouri Medicaid patients, no prior authorization is required for Mavyret. It is huge for our patients, huge for our providers, and has really decreased a lot of the administrative burden. So again, for treatment monitoring, these patients, many of the straightforward ones don't require any for the simplified treatment. The goals for monitoring would be for somebody who has more significant liver disease, assessing for the viral response to treatment. So they're on one of those pesky GERD acid suppressing medications, and you want to just make sure that that virus count is coming down. That would be a reason to check it. Or if you just suspect there's something else going on with their liver. This is just kind of a side note. Sometimes these medications can really improve the liver health and improve diabetes numbers, actually. And so you want to watch for hypoglycemia in patients who are taking diabetic medications and monitoring for that symptomatic hypoglycemia. Also, for patients who are on a medication called Coumadin, this can impact their INR, and so that's something you definitely have to monitor. So the goal is to get them through the treatment, and then 12 weeks after they finish that treatment, they will be checked for what's called the sustained virologic response, and that is the cure. So we check that 12 weeks after they've completed the direct-acting antiviral, and that's how we prove it's gone for good. For post-treatment follow-up, for patients who have cirrhosis, again, that ongoing screening, ongoing liver ultrasounds, and referring to a GI or hepatology. For non-cirrhotic patients who complete their treatment, no real routine monitoring is required. You can do routine periodic screenings for people who have ongoing risk factors because there is risk for reinfection is very, very low, but it is possible. And so you want to do routine monitoring for those patients. All right, so that's a lot of information, right? So we have a treatment, we have it successful, we have great algorithms and guidelines, but what do we have to support providers? So back in 2022, we created a Hep C provider pocket guide. And if you want actual tangible physical copies of this, my email's on the last slide. You can reach out to me and I can help get you some of these for your clinic. But these include almost all of the information that I'm presenting today about the guidelines, and there's even some information about harm reduction. You can access a digital version of this through the Department of Mental Health's website. The link is here. Honestly, if you just Google or Bing search or whatever search engine you use for Department of Mental Health and then Hep C Provider Pocket Guide, it's one of the first things that pops up. You can download it as a PDF. If anybody's interested in more like clinical education, there's Hep C Online. It's great for providers. It's absolutely free. There's a ton of CEs attached, I think almost 40, and includes pharmacology hours for people who are advanced practice nurses who need those pharm hours. And again, it's completely free, and it's a great overview of education on diagnosis, monitoring, management of Hep C. And then the Hep C Echo. So on the first and third Fridays of the month, from noon to 1 p.m., we host a hepatitis C Echo. Right now, it's hosted by Dr. Iyad Al-Sabah, and then we have a really great hub team of people from across different disciplines. So I am on it, and then we have Dr. Laura Marks. She's an infectious disease specialist from WashU. We have Patrick Kojima, and he is a clinical pharmacist at WashU. And then we also have Josh Moore, who is director of pharmacy for Mo HealthNet, who is a champion for Project Hep Cure. So we have part of the session is a didactic. So about 25 minutes or so we spend on different topics about hepatitis C treatment, all things from hepatitis C to even fatty liver disease, hepatitis B. We talk about co-infections. It's really great information. And then kind of the bulk of what we want to do are case studies. And so you are able to present a case and bring that to the Hep C Echo team to get advice on what to do for your patients. And so you can submit a case online. There's an online case form that you can use to submit those case studies. And then we talk about it as a group and give you real-time information. Another great part about this is sometimes you could get a really pesky commercial insurance plan that requires your treatment to be done in consultation with a hepatologist, infectious disease specialist, or an HIV specialist. And we have all of that on our team. And so if you have one of those and you need it for your prior authorization approval, we got you. Our team will be able to write a letter, be able to write the information that you need so that you can go back and confidently tell the insurance company, we've consulted for this case with, XYZ specialist. Through Maytech, we are also starting a Hep C mini residency. So we had our first one in August, and we will get the information out about the next one sometime. Hopefully it will be held in December. But it's a provider education series that focuses on the treatment of Hep C in primary care settings. It comes with CEs and goes over all things Hep C, harm reduction, and access to medications. It was a half-day format. I think we did our webinar from about 1 to 4 p.m. And it was really great. We had quite a few providers on the last one, and I hope it grows for the next one. Another resource that I used frequently when I first started treating Hep C is this Clinician Consultation Center. They don't just do Hep C. They also have a line for HIV PrEP and PEP and HIV treatments. But this is a warm line that you could call. It's through clinicians through UCSF that are ranging in their expertise level, clinical pharmacists, hepatologists, infectious disease specialists, that you can call and get real-time consultations about your patient. So if you've got something that you have to have answered right now, can't wait for the Hep C Echo, this is a really nice backup to have in your pocket. So the next part I wanted to go over were some patient resources for how to access those medications. So for your uninsured patient, there is an opportunity to still get medication. So there are patient assistance programs. Support Path is through Gilead for Epclusa and Vosevi, and then My AbbVie Assist is for AbbVie, which provides Mavyret. If those clients, though, are uninsured, but they're eligible for Medicaid, they will often get denied for the prescription assistance. But if they're denied for Medicaid, then they're generally still eligible for assistance. So you just need to call the patient assistance programs to be able to get that information. They're really friendly, very easy to work with them. I worked for 5 years with both sides for Support Path and My AbbVie Assist, and have always been able to get my patients their medications almost within a week or two of putting in that application. So prior authorizations. These can, again, be done if you need support for them by presenting a case to the Hepatitis C Echo team. But prior authorizations you'll often find through commercial insurance plans and your Medicare beneficiaries. Having a plan up front really helps with these, understanding what they are generally going to ask for. And I will tell you, for prior authorizations, they want to know if the patient's taken any medication before. They want to know if they're using substances. They want to know if what their genotype is, which is a test that we don't technically have to be able to provide this treatment, but most insurance companies still provide it or require it. So, if you are running into any issues with prior authorizations, this is also a really great opportunity to come to the Hep C Echo because we have a clinical pharmacist. I have a lot of experience with dealing with prior authorizations. So if you have one that you just can't get pushed through, this is another great opportunity to bring it to the Echo. We can help you work through that process so that we don't leave any patients without getting access to medication. For patients who do get their prior authorization approved, and then maybe they still have a high copay, which happens at times. There are some copay assistance resources for people who may have Medicare and have a high spend down. These are application systems that are only open at certain periods. I do know Hep C was open for some of these recently reopened. They had been closed for several months. But they, My Good Days, they will provide you, I think, up to $9,000 to cover the copays for these patients, similar with Healthwell Foundation. And then we have the Patient Access Network and Patient Advocate Fund. So if you're struggling, if your patient has a really high copay, these are great resources to look into. We also have copay coupons, so maybe the copay is high but manageable. So something like $300, a copay coupon can generally cover the cost of that copay for the patient, and then they would just have a $5 payment at the time of picking up their script. There are copay coupons available for Epclusa, Mavyret, Vosevi, and Harvoni. So before we leave things open to questions, I do want to say that help is available. We have so many options across the state of Missouri to be able to get patients and providers access to treatment and treatment resources. Again, the Maytech Hep C Mini Residency it's in its infancy. It's a brand new program that we're doing, but we're hoping to get more providers on board with treating and being comfortable with that treatment process in their settings. Show Me Echo I've really enjoyed being a part of it. I hope to continue to be a part of it for years to come. But this is such a valuable and important echo, and we have a really great team of providers and practitioners on board to be able to provide that ongoing support. So whether you are having a hard time even linking somebody to care, maybe you're at a local public health agency and you're having a hard time finding somebody who could provide care for that patient, come to the Echo. You have a provider in your clinic who's interested in treating, send them to the Echo, send yourself to the Echo, get more information. The didactics are great, but really the didactics are just a small part of the information that we share with each other. And it's really about bringing cases, bringing questions, having dialogue about what we can do to get more persons in the state of Missouri treated. And then we also, through the Missouri Department of Health and Senior Services, if you want to get more involved at a state policy and advocacy level, there's a viral hepatitis stakeholder work group. I can get you some information on how to join and be more active in that as well. We have quarterly meetings. Those are really great to be a part of because you can engage with other people, learn about successes and failures, and how we're getting people connected to care. And then the last thing, so we are starting to do telemedicine at a lot of different clinics across the state. So myself at Swope Health, we are taking telemedicine clients for hepatitis C treatment. The state has done some really great work on doing some testing initiatives and getting patients connected to care, even if they're in rural communities, to be able to get them access to that treatment. So if you are in a setting and you have patients who need access to this treatment and they don't have access and you want to get them help, you can reach out to myself and I can try to get some more information in the chat to you, but I'm happy to help provide some of that telemedicine for patients as well. And then hopefully encourage those providers or people who are testing to attend the Echo and then get comfortable treating themselves. Just a